Hello everyone, welcome to Cambridge NCLEX online classes. In this video, we are going to start a new topic that is major disorders of circulatory system, and this includes cardiovascular, blood and lymphatic systems. In the previous session, we have discussed about the major disorders of GIT system. In that session, we covered almost all the important diseases and conditions related to the gastrointestinal system, and in circulatory system we are going to see some important diseases or disorders which are in the circulation. So I hope that you have watched those videos, and if you haven't, so make sure to watch them and then start this topic. Now let's see the first condition of cardiovascular system. So first condition is hypertension. So, what is hypertension? Hypertension, also known as high or raised blood pressure, is a condition in which the blood vessels have persistently raised pressure. So, as the name indicates, when in the blood vessels there will be hyper, that is increased tension, increased pressure in the blood vessels. So, that pressure will lead to the hypertension. Blood is carried from the heart to all parts of the body. So, we will not discuss here about the physiology and how the function occurs in the heart, but I hope that everyone knows that blood is carried from the heart to all parts of the body. In the vessel, so vessel carries the blood from the heart into the body parts. Each time the heart beats, it pumps blood into the vessels. Blood pressure is created by the force of blood pushing against the walls of blood vessels. So when in the blood vessel, that is arteries, the blood is pushed by the force. So that pushing force called the pressure, as it is pumped by the heart. The higher the pressure, the harder the heart has to pump. So that is obvious that when the pressure will increase, so the heart has to work more, the heart has to pump more, and that will increase the pressure. So this was we can say that how the hypertension occurs. So we can say here that this is a normal vessel, this is a blood vessel, and blood is moving in this blood vessel. Now, when there is dilated blood vessels, so this is the normal. In pre-hypertension, the blood vessel will have more pressure and less space. This is pre-hypertension. And when there will be more narrowing of the blood vessel due to the high pressure, it will cause hypertension. Now let's see etiology and pathophysiology of hypertension. Etiology of hypertension is very complex. It begins insidiously. Changes in arterial bed causes increased resistance. So the main thing change is in the arterial bed. So in arterial bed, there is increased resistance. Resistance means the resistance force, the opposite force that blood vessel has to create, or increased blood volume. So because in hypertension we can see many causes etiology, so one of them can be change in the arterial bed, and increase in blood volume may result from hormonal or renal dysfunction. So these changes in the blood vessel, or we can say in the circulatory system, can be due to the renal dysfunction or hormonal dysfunction. Arterial thickening causes increased peripheral vascular resistance. So when there are arteries which are further branched into the arterioles. So these arterioles when get thick, so this thickness cause increased peripheral vascular resistance, or from abnormal renin release constrict the arterioles. So basically the blood vessel in which pressure has increased, so that pressure can increase due to abnormal renal constriction, increased peripheral resistance, hormonal or renal dysfunction. 90 to 95% have an unidentifiable cause. Okay, so we can see that almost majority of people have unidentifiable cause, that is essential or primary hypertension. So this is called essential or primary hypertension. Multiple factors such as renin, angiotensin, aldosterone mechanism, sympathetic nervous system activity, and insulin resistance may be involved. So, in primary hypertension, the cause of hypertension is due to the some physiological or chemical changes. It does not occur due to any other disease. So, here the hypertension will occur due to the changes in the body, that is renin, angiotensin, aldosterone mechanism. Where aldosterone level increase, there is sodium retention and hypertension. Sympathetic nervous system activity, insulin resistance. So in primary hypertension will be due to the own physiology. In secondary hypertension, the hypertension will occur due to other conditions. So this consists of 5 to 10% and have identifiable causes. So here, pathophysiology is related to the condition causing the rise in pressure. Conditions include renovascular disease, primary hyperaldosteronism, Cushing syndrome, diabetes mellitus, neurologic disorders, dysfunction of thyroid, pituitary, or parathyroid glands, coarctation of the aorta, and pregnancy. So we can see here the major difference between primary and secondary hypertension is that in secondary hypertension, the cause of hypertension will be related to the other condition. It can be due to increased aldosterone level, Cushing syndrome, diabetes mellitus, other dysfunction of thyroid and neurological disorders, and coarctation of aorta. So we know the exact reason, the cause is identifiable, whereas in primary hypertension, the cause will be unidentifiable. Now, moving on to the risk factors. So, what can be the risk factors of the hypertension? So, first of all is stress. Stress can be a risk factor that may lead to the hypertension. So, the people who take too much stress, their pressure in the blood vessel may increase in comparison to the other people. Abdominal obesity, diet that is high sodium diet, low calcium, low magnesium, and low potassium diet can lead to hypertension. Substance abuse, for example, cigarettes, alcohol, cocaine. Family history. So people having hypertension in their family tree will have a they will have more chance of getting hypertension. Increased age. So as the age increases, the ability of the blood to pump the ability of the heart to pump the blood will be same, but here the vascular resistance may differ. Sedentary lifestyle. So sedentary lifestyle can lead to increase in the blood pressure. Hyperlipidemia. So when the low density lipid, that is a bad cholesterol. This is bad cholesterol. So when there will be increased LDL and cholesterol levels and decrease HDL, HDL is a good cholesterol. So when good cholesterol decreases and bad cholesterol increases, so that is also a risk factor for hypertension. If person is African-American heritage, type 2 diabetes mellitus, renal disorders, so all these risk factors can lead to the hypertension. Often asymptomatic diagnosis requires 3 assessment of elevated BP on separate occasions. So in acute hypertension, if hypertension is of new case, it may be asymptomatic and symptoms may appear later in the life. So sometimes diagnosis will require 3 time assessing BP. So we have to assess the blood pressure 3 times on these separate occasions. So it can be before meal, after meal, all it depends. So after taking 3 blood pressure measurements, then we have to confirm that yes, patient has hypertension. Now let's move on to the classification of blood pressure. So what is the normal blood pressure? Systolic blood pressure less than 120 mm of Fg and diastolic less than 80 mm of Hg. So the normal is 120 by 80 mm Hg. In pre-hypertension, systolic will be 120 to 139 mm Hg or diastolic will be 80 to 89 mm of Hg. So when the patient is in the pre-hypertensive phase, it means that prone to develop hypertension. So that will range from 120 to 139 and diastolic will be 80 to 90 or 89. Stage 1 hypertension. The systolic blood pressure will be 140 to 159 and diastolic will be 90 to 99 mmHg. In stage 2 hypertension, systolic will be 160 mmHg or more, or diastolic will be 100 mm of Hg or more. And hypertension increases risk for coronary artery disease, heart failure, myocardial infarction, brain attacks, retinopathy, and nephropathy. So, as we can see that in hypertension, pressure increases. So that pressure when increase in the chronic state, it increases for a long time. So it can damage the brain, it can damage the heart. There can be changes in the retina and in the nephrons. So hypertension can lead to many complications. So it need to be controlled. So we have seen here the classification of BP: normal in pre-hypertensive state, stage 1 hypertension, stage 2 hypertension. Now moving on to the clinical findings. So what we will find in the patient. In subjective data, patient will report headache. That is on the occipital area. In the occipital area, the headache will be there. So we can see here if this is the head of the patient. So patient will report headache over this area, back of the area, that is occipital area. Lightheadedness. Tinnitus can be occur. There will be a sound or tingling sensation in the ears. Easy fatigue, visual disturbances, and palpitations. So all these are the signs or patient report. In objective data, we will observe that BP will be more than 140 by 90 mmHg obtained on 3 separate occasions. Retinal changes, renal pathology, for example, azotemia will be there. So there will be secretions of ammonia from the urine. Epistaxis can occur, that is blood from the nose can occur. And cardiac hypertrophy can be seen, that is hyperdevelopment of tissues in the heart can be seen due to the hypertension. So all these things we can see. We have to make sure that whenever we are assessing a patient who is complaining of the headache, lightheadedness, then we will assume that patient has hypertension, and we will check the patient for azotemia, in which there will be increased urea nitrogen in the urine, increased level. Blood from nose can occur, cardiac hypertrophy can be seen in the diagnostic test, and retinal changes can be seen. So all these things we have to observe in the client. Now moving on to the therapeutic interventions. So what will be the management provided to the patient? So first of all, whenever patient reports hypertension, the first thing is lifestyle modification. Lifestyle of a person is very important. It plays an important role in controlling the hypertension. So patient has to control the weight or reduction of the weight to attain a body mass index of 18.5 to 24.9. So this is the range of the body mass index that the patient has to maintain. If patient has BMI more than 25, the patient is prone to get obese. So it has also the categories which we have discussed in the previous video. So in body mass index, there are various categories, and according to that, the obesity has been graded. But the optimum BMI should be 18.5 to 24.9 kg per meter square. Second and most important thing is dietary approaches to stop hypertension. This is called DASH diet. In DASH eating, we approach the dietary pattern to stop the hypertension. For example, eating fruits, vegetables, and low-fat dairy products that are rich in calcium and potassium. So the patient has to include all the fruits, green vegetables, and she has to stop eating fatty foods and deep fried foods. Sodium should be restricted, as sodium intake leads to hypertension, so it should be restricted less than 2.4 gram per day. Aerobic exercise for at least 30 minutes on the most days is very, very important to increase the cardiac health. So doing aerobic exercises helps in improving the cardiac health. Alcohol moderation. So alcohol should be limited. No more than 1 drink daily for women and 2 for men. So these are the lifestyle modifications that patient has to follow. After changing the lifestyle, after improving the lifestyle, if there is no improvement, then drug therapy has to be started. And in most of the patient, drug therapy is there. So pre-hypertension, it is only for compelling the indications to tell if the hypertension will occur or not. In stage 1 hypertension, thiazide diuretics for the most. So if the stage 1 hypertension is there, stage 1 we have seen here where the BP will be from 140 to 159 to 90 to 99 mm of Fg. It means that BP will be less than 160 by 100. It will be less than 160 by 100. This is the stage 1 hypertension. So in this case, the physician will recommend thiazide diuretics. So in thiazide diuretics, patient will be prescribed with ACEIs, that is enalapril, captopril. So the physician will recommend ACE inhibitors, angiotensin convertase enzyme inhibitor. So this is the hypertensive drug which can be given. Second is the ARBs. So in ARBs, losartan, irbesartan can be given. ARB are the angiotensin receptor blocker. Okay, it ends from the prefix sartan. CCBs are the calcium channel blocker. In this, we will include amlodipine, nifedipine, etc. Beta blockers like atenolol, metoprolol. So all these drugs can be given in the stage 1 hypertension. In stage 2 hypertension, secondary drugs are added to thiazide diuretic for the most. So other drugs can be included to the thiazide diuretic. In other interventions, we have to advise the patient to stop smoking because smoking leads to vasoconstriction. Relaxation modalities such as biofeedback and imagery, anti-anxiety drugs. So relaxation therapies can be given like biofeedback and imagery therapy and anti-anxiety drugs can be given. Now moving on to the nursing care of clients with hypertension. So what is the nursing care that has to be provided to the patients with hypertension? So first of all, we need to assess the patient. We need to assess the vital signs in both upright and recumbent position. This is very important. Whenever you are measuring BP of the patient, so you have to measure the blood pressure in upright and recumbent position as well. You have to use always appropriate cuff. Width should be 40% of the arm's circumference. This is very, very important here. That width of the cuff should be 40% of the arm's circumference. It should cover 40% of the arm circumference. Avoid errors of parallax when reading sphygmomanometer. So this is very important. We have to check the baseline weight so that we can advise for the lifestyle modifications. Presence of risk factors and clinical evidence of the target organ damage. So we have to look for the evidence that what is the target organ damage and what are the present risk factors in the patient. Now moving on to the planning and implementation. So what is the planning that we will do for the patient? So after measuring the BP, after seeing all the risk factors, we will then monitor the levels of electrolytes in the body. For example, we will check blood urea nitrogen, we will check the creatinine level, lipid profile, and urine for protein. So if we check the blood urea nitrogen creatine, so we look for the kidney functioning, so that we can advise the medicines according to that. We have to check lipid profile to see the functioning of the liver and urine for the protein. Encourage weight reduction if indicated. Weigh daily to monitor the fluid balance when there is threat of heart failure. Teach to monitor own BP. So patient should know that how to measure the BP, because a patient can notice the complications. A BP of 180 by 120 mmHg or higher represent a hypertensive emergency. So if the BP of the patient occur elevate more than 120 by 180 by 120, that's why we have to tell the patient to learn how to monitor BP of phone, so that the patient can know that when is hypertensive emergency occurring. So in that case, advise to change the position slowly and avoid hot showers to prevent orthostatic hypotension when taking antihypertensives. So when patient is taking hypertensives, there's tendency that BP will drop. So whenever patient gets up from the bed, we have to tell the patient that whenever you are getting up from the bed, first sit down and dangle your legs on the bed, dangle your feet, so that there will be a proper circulation. Then after 1 or 2 minutes, you should get up to avoid orthostatic hypertension. And you have to avoid hot showers. Okay, so all these measures should be done to prevent the any adverse effects. We have to support the expression of emotions, encourage relaxation techniques. So doing meditation, doing yoga can help in relaxing and decreasing the blood pressure. Reinforce that hypertension is not cured but controlled. So we have to reinforce in the patient that if you will maintain a good lifestyle, hypertension will be in control. But the moment you will leave the that lifestyle, hypertension will come. So it is not cured, it is controlled. We have to educate the client and family regarding drugs, follow up care, activity restrictions, smoking cessations, limiting alcohol intake, and diet. Note that many salt substitutes contain potassium chloride rather than sodium chloride and may be permitted by the healthcare provider if there is no renal impairment. So here we can see that generally salt contains sodium chloride, but there are some salts that contain potassium chloride. So if patient has high BP and we want the patient to avoid taking sodium, so we can advise patient to take the salt made up of KCl. But here we have to remember that patient should be not having any renal disease. That we have to see, because if patient has renal disease, so potassium level can increase and it can lead to the further complications. Now moving on to the evaluation or outcome. So what we expect at the ending. So we expect that patient maintains BP at acceptable level, patient adheres to the therapeutic regimen, and patient verbalizes needs for distress reduction. When patient follow all these things, then the nursing care is successful. Next is coronary artery disease. So this is a very important topic and this includes many conditions. So in coronary artery disease, the coronary artery, which is the main artery in the heart, is having some problem. So this includes ischemic heart disease, coronary heart disease, atherosclerosis, angina pectoris, and myocardial infarction. So we will discuss all these things in detail. So first we will see what is coronary atherosclerosis. So we will see that deposition of fatty plaques along inner wall of coronary arteries leads to inflammation. So when in coronary artery there is deposition of fatty plaque on the inner wall of the artery, this leads to the inflammation. And when there is inflammation, macrophages infiltrate endothelium. So whenever there is inflammation, our immune response let the macrophages go in the endothelium, causing further damage and development of the atheroma, that is fibrous cap over fatty deposits. So when there is the plaque deposition and due to the fat, there is the formation of atheroma, that is fibrous caps on the fatty deposits. This leads to narrowing and possible obstruction. So this leads to the obstruction of the artery, that is coronary artery, and it also affects the peripheral and cerebral vessels. So we will see here that this is the coronary artery, and when the fatty plaque is deposited over the artery, this leads to the obstruction. Second is angina pectoris. So what is angina pectoris? It is the episodic pain experienced when the blood oxygen level cannot meet metabolic demands of the muscle. So every muscle has some demand for the oxygen, and when that blood oxygen level is not achieved by the muscles, this lead to the spasm and pain on that region. So when the oxygen demand is not met, this leads to the pain on that muscle. So this is angina pectoris. In addition to atherosclerosis, this temporary, so we have to remember that this is a temporary ischemia. This may be precipitated by coronary artery spasm. So if patient has coronary artery spasm already, so this will be precipitate the ischemia. And if patient is doing strenuous exercise, so this will increase the demand of oxygen and can lead to the angina. Heavy meals. So when patient will have heavy meals, all the blood circulation will move toward the abdomen, and this can lead to the angina pectoris. Hyperthyroidism. So increase in the thyroid hormone level can also lead to the angina pectoris. Exposure to cold and emotional stress. So these all things or risk factors can be seen that can increase the risk of angina pectoris. So we have to remember that angina pectoris means pain on the muscle due to deprivation of the blood oxygen level. Now, what are the types of angina? So, first of all, there is stable angina. In stable angina, when an event will occur, so when the pain will occur, it will occur during physical exertion or mental stress. The pain usually goes away a few minutes after you rest or take your angina medicine. So, in stable angina, the angina will occur due to some precipitating factor. It can occur due to physical exertion or mental stress. And when you will rest or you will take your medications, the pain will go away. Second is unstable angina. Unstable angina is new or occur more often. So it occurs more often and more severe than the stable angina. So this is more severe. Unstable angina can also occur with or without physical exertion. So there can be no precipitating factor. It can occur anywhere and anytime. It cannot or it may not be relieved by rest or medication. Unstable angina is a medical emergency since it can progress to heart attack. So there is a difference between stable and unstable angina. That stable angina will lead due to some precipitating factor and it will relieve when the precipitating factor will be removed. But in unstable angina, there will be no precipitating factor and it can further lead to the heart attack. So this is a medical emergency and need to be taken care of. Third is microvascular angina. So what is a microvascular angina? Microvascular angina is a sign of coronary heart disease affecting the tiny arteries of the heart. So here there are some tiny arteries of the heart that will be affected. Microvascular angina events can be stable or unstable both. They can be more painful and last longer than other types of angina. And symptoms can occur during exercise or at rest. So it is a mixed form of the stable and unstable angina. It can occur due to exercise or also can occur during the rest. Medicine may not relieve symptoms of this type of angina. So basically, it will occur due to the microvascular changes in the heart. Fourth is a Prinzmental angina. This is also known as variant angina. So Prinzmental angina is rare. It occurs when a spasm, that is a sudden tightening of the muscle within the artery of your heart, causes the angina rather than the blockage. So when there will be spasm of the muscle, so that spasm will lead to angina. This type of angina usually occurs when you are at rest and the pain can be severe. It usually happens between midnight and the early morning. So we have to remember that Prinzmental angina can occur at the midnight or early morning and in a pattern. Medicine can ease the symptom of variant angina. So these were the four types of the angina. Now moving on to the third condition, that is myocardial infarction. So what is myocardial infarction? As the name suggests, the muscle of the heart will have Infarction. Infarction means that there will be decrease in the oxygen supply to the tissues that will lead to the ischemia. So, acute necrosis of heart muscle caused by interruption of oxygen supply to the area, resulting in altered function and reduced output. So, when in the heart muscle there will be necrosis, acute necrosis. Acute necrosis means that oxygen is not able to go in the tissue, and due to that, tissue will have color change and will be necrotized. So there will be necrosis. Necrosis means that there is no oxygen supply and the tissue is dead at that area. So interruption of oxygen supply will lead to ischemia and will lead to necrosis. And due to that, there will be alteration in the function and there will be reduced output. So there will be heart load and the heart will not able to pump enough blood. So this is a myocardial infarction that is also known as MI. Now, what are the risk factors? So risk factor can be family history. History of coronary artery disease, angina will have the more prone to be at the risk of MI. Increasing age, particularly women. Gender, men, women, especially after menopause, that is estrogen, seems to provide some protection. Okay, so in men, there will be less risk than the women. Race, risk appears higher in African Americans. Cigarette smoking contributes to vasoconstriction, platelet activation, arterial smooth muscle cell proliferation, and reduced oxygen availability. So cigarette will have this, effect because there will be vasoconstriction. So platelet activation can occur and cell proliferation can lead to reduced oxygen availability. Hypertension, widened QR complex, that is bundle branch block. So this is in this ECG, this is the Q, this is the P, this is the QRS, and this is the T wave. So QRS complex will be wide. This leads to the risk of these coronary artery disease. Now moving on to the other risk factor, that is hyperlipidemia. So hyperlipidemia is a very important and major cause of coronary artery disease. So in hyperlipidemia, there is an increase in the total cholesterol level. So what we can see in the total cholesterol level? So in total cholesterol, there will be increase in the low density lipid, that is 130 to 150 mg per deciliter. And this is high. And when they will be level 160 mg per deciliter or more, this will be very high LDL. So low density lipid, that is a bad cholesterol, will be high in the patient. There will be increased ratio of total cholesterol, that is LDL to HDL ratio will be increased. Low HDL, so good cholesterol will be low in the patient, that is less than 40 mg per deciliter. HDL greater than 60 mg per deciliter. So we have to remember that HDL is a good fat. And if the HDL level is more, that is more than 60 mg per deciliter, it helps to protect against the coronary artery disease. So we have to remember that the HDL should be more than 60 mg per deciliter. But in patient having CAD, there is the HDL 40 mg per deciliter or less. But LDL will increase. So LDL will increase more than 130 mg per deciliter. Increase triglycerides. So triglycerides should be low, but here they will increase, that is range from 200 to 500. And in very high case, it will be more than 500 mg per deciliter. So all these values indicates that patient have risk of coronary artery disease. So low density lipid will be increased, high density lipid will be low, triglycerides will be high. Now moving on to the other risk factors. So obesity. Abdominal obesity can lead to coronary artery disease. Sedentary lifestyle, type 2 diabetes, stress, and innate competitive aggressive type A personality seems less important than amount of stress and client psychological response. So patient having type A personality seems less important than amount of stress and client psychological response. So it depends upon the behavior of the patient. Metabolic syndrome. Cluster of signs including hyperlipidemia, low HDL, abdominal obesity, increased BP, insulin resistance, increased level of C-reactive protein, and increased fibrinogen level. So all these, if are present in a same patient. So if patient has all these type of the condition, then this is called metabolic syndrome. And this is a risk factor of the coronary artery disease. Now, what are the clinical findings of the coronary artery disease? So in subjective data, the patient will report retrosternal chest pain that may radiate to arms, jaw, neck, shoulder, or back. Pain described as pressure or crushing pain or vise-like pain. Palpitations will occur. Apprehensions occur. Feeling of dread impending doom. Dyspnea, nausea, vomiting, pain of angina can be associated with the activity and generally subside with the rest. Asymptomatic with silent ischemia. So it depends from patient to patient. So basically, if patient has, angina, so patient will report a pain that will radiate to arms, jaw, and neck, and the patient will report that the pain is like a pressure or crushing pressure. Patient will have palpitations and patient will be very anxious, and patient will feel that there is something impending doom. There will be dyspnea, nausea, vomiting. All these things can be seen in the patient. But if there is silent ischemia, so patient will be asymptomatic. Atypical symptoms of angina in women include exertion. So in women having atypical symptoms, the symptom will be exertion related to discomfort above waist, burning or tenderness to touch in the back, shoulder, arm, jaw, abdomen, overwhelming fatigue, indigestion, feeling of unease. So all these can be the symptoms that are reported by the patient having angina. In objective data, we will see that there will be ECG changes that will relieve ischemia. So what are the ECG changes? There will be T wave inversion. So this is the P, Q, R, S and T. So T wave will be inverted. There will be ST segment elevation or evidence of MI, that is presence of Q wave. So there can be presence of the Q wave. So Holter monitoring is a method. This is a Holter monitor device that is used to detect the changes associated with the activity of the daily living. So Holter monitor helps in detecting the ECG of the patient for at least 24 hours. So this is the objective finding. Other findings can be elevated levels of serum enzymes. So in the patient having MI, there will be increase in the serum in the patient and isoenzymes with MI. So first enzyme that is seen to be elevated is cardiac troponin T, that is CTNT. So this level increase within 3 to 6 hours of MI. So if patient has MI and patient come to the hospital, so the cardiac troponin will increase within 3 to 6 hours and it remain elevated for 14 to 21 days. That it remains for at least 3 weeks. So we have to remember that cardiac troponin will increase within 3 to 6 hours and will remain for 3 weeks. Cardiac troponin 1 or I level rises 7 to 14 hours. So these level rise after the cardiac troponin T, that is 7 to 14 hours, and it remain only for 5 to 7 days, that is for 1 week. Creatinine kinase, that is CK, level increase 3 to 6 hours after infarction and peak at 24 hours and return to normal level within 72 hours. So if patient come with MI and we want to check that if we want to confirm the MI, then we can check the cardiac troponin T because it rises within 3 to 6 hours and it remains for 14 to 21 days. MB isoenzyme of creatinine kinase, CKMB. So this is also an serum enzyme its level elevate 4 to 6 hours after pain, peaking within 24 hours. So CK and CKMB peak within 24 hours and return to normal within 72 hours, specific for myocardial damage. So we can see here that in creatinine kinase and CKMB, the level elevate from 3 to 6 or 4 to 6. So almost these two have same values and peak at 24 hours and return within 72 hours. Myoglobin. So myoglobin level increase in 1 to 3 hours. The level of myoglobin increase first. So this is first elevated and return to normal into 24 hours, 12 hours. So it returned to the normal hour very shortly. C-reactive protein. So if patient C-reactive protein is elevated, this suggests inflammation of vascular endothelium and coronary artery calcification. So CRP indicate that there can be calcification of the artery. Doppler flow study. Doppler flow study will discover any type of ischemia. Cardiac nuclear scanning, that is thallium multigated acquisition scan, known as MUGA, or echocardiographic studies help determine extent of vessel involved. Sympathetic nervous system response. So we can see the sympathetic activity, that is pallor, tachycardia, diaphoresis, vomiting. All these will indicate the MI symptoms. Signs associated with MI. So if you want to check, so we can check dysrhythmia, elevated temperature, elevated sedimentation rate, that is ESR, and increased WBCs. So all these also indicates the MI. So all these are the objective findings that we can see in the patient. Now moving on to the management, that is therapeutic interventions. So first of all, let's see how to prevent MI. So there should be supervised exercise program to avoid ischemia, but promote collateral circulation and increase HDL. Weight control should be there, smoking cessation to decrease vasoconstriction, dietary restrictions of sodium, cholesterol, and total and saturated fat, management of hypertension, hyperlipidemia, and diabetes. In pharmacological management, nitrates, beta blocking agents, calcium channel blocking agents, antilipidemic antiplatelet agents, and ACE inhibitors. So all these drugs that helps in reducing the BP. So we can see that CCB, nitrates, beta blockers, ACE helps in reducing the blood pressure, whereas anti-lipidemic will reduce the lipid level and anti-platelet will prevent the platelet formation and decreasing in the blocking. Supplemental oxygen can be given during anginal attack to prevent the oxygen deprivation. Percutaneous coronary interventions, that is PCI, such as percutaneous transluminal coronary angioplasty, coronary artery stent placement, and atherectomy to vascularize the myocardium. So when there is MI, the interventions that we can do is we can remove the fat deposition. So if there is atheroma, that is fat deposition, so that can be removed. That is atherectomy. And if there is blockage in the heart, so stent can be placed. Stent will help in preventing narrowing of the artery. And third is percutaneous transluminal coronary angioplasty. So this is percutaneous transluminal coronary angioplasty. In this, what we will do that if this is a patient, we will insert the catheter from the groin region. The catheter will be inserted. And what is the main purpose? The main purpose is to dilate the coronary artery. So if there is a fat deposition, so that catheter will be inserted and that catheter will contain a balloon. So this balloon will dilate the blood vessel and will help in providing enough blood circulation. So basically, the inflated balloon helps in decreasing the narrowing of the artery. So this is the PTCA. Coronary artery bypass graft. This is also can be done. So if all the medical regimen are not successful, then we have to create a bypass from the coronary artery. Okay, so all these are the management. Now, management of acute MI. When there is an acute attack of MI, if patient has sudden attack of MI, then what is the management? So first of all, we have to improve the perfusion. We have to provide enough oxygen. So we will administer the aspirin immediately. Aspirin helps in decreasing the pain. Then beta blockers or angiotensin 2 receptor blockers for left ventricular systolic dysfunction can be given. Thrombolytic therapy within 30 minutes of arrival and anticoagulants can be given. So if MI is due to the thrombus, that is due to any blockage in the artery, then thrombolytic agent can be given within 30 minutes. This is very important. This should be given within 30 minutes, then it is only effective. IV nitroglycerin can be given to reduce BP. ACEI, that is ACE inhibitors, can be given. Dysrhythmics to maintain cardiac dysfunction, that is antidysrhythmics. PCI within 90 minutes of arrival at emergency department. So if patient is having MI, our main goal is to provide enough oxygen. So in PCI, percutaneous intervention, we will try to reduce the narrowing. We will dilate the vessel. So this is a non-surgical invasive procedure that will give the relief to the narrowing or occlusion of the artery, and it will improve the blood circulation. So it should be done within 90 minutes of the arrival at emergency department. Intra-aortic balloon pump that inflates during diastole and deflates during systole to decrease the cardiac workload by decreasing afterload and increasing MI perfusion of the cardiogenic shock. So this is the role of the intra-aortic balloon pump. So when this inflates during the diastole, that is when the heart is relaxed, when the pumping has occurred. So during diastole, when the heart has pumped out the blood, this balloon inflates, and this deflates when the systole occurs, which is that when the blood comes in the heart. So this is done to decrease the cardiac workload by decreasing the afterload and increasing the MI perfusion. Aspirin, beta blocker, and possible antilipidemic may be prescribed at the discharge. Promotion of comfort and rest. So this is the very important thing. We can advise analgesics as per doctor's advice, as morphine, to reduce pain, anxiety, and cardiac workload by decreasing the preload and afterload. Oxygen to improve tissue oxygenation, maintenance of bed or chair rest to decrease oxygen tissue demands, diet therapy, that is 2 grams of sodium diet or clear liquids depending on the presence of nausea. Continuous monitoring of pulse oximetry, cardiac monitor, that is rate, evidence of ischemia, dysrhythmias we have to see. Vital signs we need to check to see the blood pressure. Hemodynamic monitor will pulmonary artery catheter will be done. So these all are the management of the MI. Other thing is assessment of complications of MI. So after the MI attack, complications that can occur are the dysrhythmias, cardiogenic shock, pulmonary edema caused by acute heart failure, thromboembolism, extension of MI, pericardial effusion, and cardiac tamponade. So all these are the complications that can occur after the MI. Next is the nursing care of clients with coronary artery disease. So what is our role here? So first thing we have to assess for the chest, arm, shoulder, neck, jaw pain. We have to check for the precipitating factors like exercise, cold, stress, etc. We can see the risk factors that are the non-modifiable, modifiable, vital signs, intake output, that is fluid volume overload is dangerous if cardiac output is compromised. We have to check for the adventitious breath sound and dependent edema with impending failure. So if there is the heart failure, so there can be changes in the breath sound. Restlessness, dyspnea, skin diaphoresis can be seen, pallor, cyanosis can be seen. If MI is suspected, continuous ECG monitoring should be done to detect changes in the rate, rhythm, and conduction of impulses. Life-threatening dysrhythmias, for example, ventricular fibrillation should be noted. Ventricular standstill, dysrhythmias like premature ventricular complexes close to T-wave, ventricular tachycardia, Torsades de Pointes. So what is Torsades de Pointes? A ventricular tachycardia with a prolonged QT interval that is linked to the rapid deterioration, and atrial fibrillations. All these are the dysrhythmias that we will discuss in the further slides, and these can be complications in the patient. So if patient is suspected with MI, so we have to check for all these dysrhythmias. What is the planning for the patient? So we have to teach the signs and management of cardiac ischemia. So that is rest, nitrates, seek emergency care if ineffective. Encourage prophylactic administration of nitrates. Reinforce need to avoid exertion, that is shoveling snow and exposure to cold. However, emphasize the need for regular exercise approved by the healthcare provider or participation in cardiac rehabilitation program. Support involvement in smoking cessation, weight control, and exercise programs. Encourage the dietary program. For example, we have to advise for low cholesterol, low fat. Substitute the unsaturated fat for saturated fat and low sodium, that is 2 grams per day. Replace vegetable oils high in polyunsaturated fatty acids with those high in monosaturated fatty acids, such as olive oil and canola oil. So, we have to tell the patient that you need to take monosaturated fatty acids rather than the polyunsaturated fatty acids, and you have to consume the low cholesterol, low fat diet. Eat fish high in omega-3 fatty acids several times per week, that is salmon, tuna, halibut. Follow DASH diet, increase intake of high fiber foods such as fruits, vegetables, cereal grains, legumes. Soluble fiber is particularly effective in reducing blood lipid level. That is oat, bran, legumes, low fat dairy should be given. Eliminate stimulants such as caffeine. So all the vasoconstrictions like coffee, tea, chocolates, colas, energy drinks that can precipitate dysrhythmia should be discontinued. We have to educate the patient about medications to provide emotional support during regarding alteration in lifestyle, provide care after acute MI. So in care, we have to document dysrhythmias and respond per protocol. Medication, defibrillation, or CPR can be given according to the protocol. Reduce cardiac demand. So we have to administer the oxygen, analgesics, vasodilators should be given, and other medications as prescribed. Reduce risk for sensory overload. So we have to orient to unit and equipment, allow time to express feelings, and encourage short visits by the significant others. So restricted entry of the people should be there, and use measures to prevent sequel of diminished activity, thrombophlebitis, pneumonia, constipation, skin breakdown, and deconditioning. So we have to prevent the complications that can occur due to diminished activity, as the patient will have on the bed rest. So skin damage, thrombophlebitis, pneumonia, constipation, all these things can occur. So we have to always take care of all these things. In evaluation, we have to make sure that patient remains free of chest pain, verbalize, reduce anxiety, adheres to prescribed regimen, that is dietary, pharmacological, and exercise, and maintains oxygen saturation at 95% on room air. So this we expect at the end. So this was about the coronary artery disease. So this was all about this video. We discussed about the coronary artery disease and hypertension. I hope that this video was helpful to prepare for your coming exam, and we will meet in the next video and we will discuss some more disorders of the circulatory system. Till then, keep practicing the questions, keep learning new things. Thank you.